Like you said, the patient was admitted to the hospital because of acute onset of right facial drop, right arm weakness, and some difficulty speaking. When I had seen the patient, symptoms had started 6 hours ago while she was at the breakfast table. The patient had no headache, no diminishment of consciousness, no abnormal involuntary movements. Past medical history: the patient had long-standing hypertension and an MI 4 years ago that was treated with an angioplasty. The medications that she's on are low pressor, aspirin, and Zocor. She is a non-smoker, and patient was put on anti-clotting medications, and I stabilized her blood pressure. There was a CT scan performed, and it confirmed and differentiated between an ischemic stroke and a hemorrhagic stroke. In the hour when I had seen the patient, symptoms were nearly resolved. She had a blood pressure of 135/87, a heart rate of 62, some drooping in the corner of her mouth, and she was able to fully elevate the eyebrows. She had a strength of 4 out of 5 in the right arm, and all neuro examinations were normal. I'll see her for a follow-up MRI to identify any viable tissue that's potentially at risk. I want her to take her medications regularly, and she's stable to start PT, OT, speech therapy, meet with a dietitian, and the nurse will take care of her.
All right. Nurse Tiff?
Okay, my plan of care for Mrs. Jones, obviously I'm going to be checking her vital signs and make sure to administrate her meds on time. Also, I'm going to assist her gag reflexes and ability to swallow to make sure that she can eat and not choke. I'll be working on her affected side during ADLs to help get mobility in that side. I'll be sure to maintain her skin integrity by repositioning her throughout the day. I'll be checking her mood since a lot of stroke patients develop depression. And then also I'll be working with PT and OT to help implement any assistive devices that you guys give her. And that's where we're going to start right now. Does anyone have any questions?
All right. What's the view from physical therapy?
All right, guys. Because she had a stroke, it's very important that she gets her physical therapy. We're going to work with her like the brain plasticity. It's like she can learn a lot faster, so it's important we start early. So my role is to get her back to like being able to ambulate throughout her house, negotiate stairs, transfer to and from her bed, and if she happens to fall, teach her how she can get back up. She is at a fall risk, obviously, because her balance and proprioception's off because of the stroke. She will most likely need a hemi walker to ambulate until her strength returns, if it does, or another type of device. So with everything we're doing, it's my job to educate her about the stroke, how it will affect her, and how she can adapt. And also I need to educate the family on proper transfers, and if they're around, they can transfer her out of bed and stuff if she needs it. So based on my plan of care, Kelly, you mentioned she was on blood pressure medication, so that's good to know, so I don't push her and have to watch her vital signs closely. And Molly, she's having trouble describing the layout of her house due to her speech problem. Can you contact the family and get a layout so I know how to make her goals?
Sure.
Figure that out. And Tiff, because of her high blood pressure, can we work together here so she can get her medication before I treat her?
Mm-hmm.
That way, her blood pressure doesn't get too high while we're doing therapy.
Sure.
All right. That's it.
All right. Occupational therapy.
All right, we're going to work hand in hand with the physical therapist, and what we're going to do is work mostly on her ADLs, so her showering, her feeding, and her ambulating. We're going to give her some adaptive devices to help her with those activities, and we're also going to give her a splint to help her with her right upper extremity since she's lacking some function with that. And we're going to work on her upper extremity and her intrinsic hand strength, and also we're going to work with the speech therapist to help her with her eating and her talking. And we also have to remember to check out her mental status because she has gone through a lot of stressful happenings so far. So that's about it for now.
Speech therapy.
Okay, everyone. On my initial eval, I also saw that Mrs. Jones was having trouble communicating, secondary to the dysphagia caused by the stroke. We will be working on this throughout her time here to facilitate reuse of her tongue and facial musculature. If we can work on developing the muscles in her tongue and in her face, then she'll be able to speak again as well as display facial expressions. The patient is also demonstrating dysphagia, causing difficulty with swallowing and eating. I'm going to be giving exercises to potentially regain function of her throat musculature. Also, I will be in contact with Kristen, the dietitian, in order to develop a new diet involving puree solids that will enable her to be able to eat more effectively while she's here in our care. Does anybody have any questions?
No. Dietary?
Alright, I've been working with Mrs. Jones journaling. We're trying to promote a healthy lifestyle overall. With her past medical history of the MI and the recent stroke, we want to prevent like a second stroke from happening. So we've been working on journaling her foods and maintaining that healthy lifestyle. We also want to maintain exercise with PT and possibly work with OT, maybe with some functional ADLs, going to the grocery store, learn to pick more, fruits and vegetables, which we're pushing at this point. We want to also promote a low-fat and low-sodium and a low-cholesterol diet, again, just to prevent the secondary stroke. And our goals are just to progress from the pureed solids to solid foods. We want to come in small pieces and start with soft foods like oatmeal and bananas and progress from there, depending on how she turns out. So, any questions?
Social work.
Mrs. Jones and I have discussed what she can expect upon her return home. Although she was living alone prior to incurring the stroke, we discussed the availability of her family members coming to help her at her home and making arrangements for long-term stays. I've also educated her and her family on various healthcare resources to contact for help, as well as set up her follow-up care and transportation to those scheduled appointments, and referrals for further care, such as various PT settings that she'll see outside of the hospital, or she'll transition to home health and eventually outpatient. I'm also here for the patient to advocate for additional services she may need, such as assistive or adaptive devices, and like I said earlier, PT, OT, and speech therapy following discharge.
Alright, so that sums up our meeting for this week. We'll have another meeting about Mrs. Jones, about her discharge planning next week. If there's any more questions, you guys can come to me or go to each other.